We will be introduced to a new molecule in this session, surmounting obesity with Tirzepatide. I request Chairpersons Dr. M.L. Bhansali and Dr. Silima S Tarenia to come up on the stage. Dr. M.L. Bhansali. Now I request Speaker Dr. Sujoy Ghosh, Consultant Endocrinologist, Manipal Hospitals, Dhakuria, to grace the dais.
Good afternoon, everyone. So today we have with us none other than Professor Sujoy Ghosh, sir, for the deliberation. Sir doesn't need any introduction, just that recently sir has been elected as the President of Endocrine Society of India. Over to you, sir.
Thank you. So without wasting much time, let me try and talk about Tirzepatide, the new molecule. My job is relatively easy because we had several talks on obesity about an hour ago, and this is just an extension of what we have already heard. So first of all, a disclaimer that this is a sponsored talk by Eli Lilly. Now, the previous sessions where you heard about incretin-based therapies, whether oral or injectable, they were all GLP-1 based therapies. And the molecule that I'm going to talk about is both a GLP-1 as well as a glucagon GIP peptide agonist. Now, when both of these are taken together, that is GIP and GLP, there is an additive effect in terms of reduction in appetite and calorie intake, and there is reduced craving for food. The GIP has certain specific effects which the GLP-1 does not have, particularly at the level of the adipocyte, wherein lipolysis, intra-adipocyte fat trafficking is altered, as a result of which fat metabolism is increased, fat redistribution occurs, and possibly that is one of the reasons why it might have even greater benefit in terms of an anti-obesity drug. And there is predominant loss in fat mass rather than lean mass. Now, the entire set of programs, that is the studies that have been conducted with Tirzepatide, have the mnemonic Surmount, and I'm going to talk to you about this entire Surmount program. To give you a brief overview, Surmount 1 is the first of the studies which essentially looks at weight management in people who do not have diabetes. Remember, a small proportion of people in Surmount 1 did have pre-diabetes, and the results of that is, though exploratory in the sense, did show prevention of progression of pre-diabetes to diabetes. Surmount 2 is a study in which you're looking at people with type 2 diabetes, where you're looking at weight management. Dr. J.J. Mukherjee clearly mentioned also that all of these drugs, when you use them in people with diabetes versus without diabetes, the ones who have diabetes, they have less weight loss compared to those without diabetes. Surmount 3 is a situation where you're looking at a group of people who already had intensive lifestyle measures. Dr. Mukherjee was trying to tell you what is the weight loss after considering what has happened in the placebo group. So if you look at Surmount 3, you will know that you've put in all of the so-called non-pharmacological therapies and then given the drug. What impact does it have? Surmount 4 is a weight maintenance trial. That is, you have a run-in period where you have a group of people who have been given the drug, and then in one group you stop the drug and in the other group you continue the drug to see what happens to the weight that was lost, how much of that do you regain, and what happens to the group that continued to take the drug. And Surmount 5 is an open label trial which directly compares semaglutide injectable versus Tirzepatide in terms of weight loss. So coming to the first study, that is Surmount 1. I told you this is an RCT comparing people getting 3 arms of Tirzepatide, that is one group getting 5 milligrams, the second group getting 10 milligrams, and the third group getting 15 milligrams of injectable Tirzepatide subcutaneously once weekly compared to the placebo group. There's more than 2,500 individuals at about 120 sites. And what we can see is, over a period of time, the placebo group lost only about 2.4% of weight, whereas, as you can see, with the 5 milligram dose of tirzepatide, there was a 16% weight loss at about 72 weeks. That is about a year and a half. And if you look at the other two doses, that is 10 and 15 milligram, the weight loss was above 20%. Now, obviously, everybody is not going to have the same kind of weight loss. So, one of the things that was discussed is any drug to be called a weight loss drug, you have to lose at least 5%. So, if you look at what proportion lost 5%, you can see almost everybody lost 5% weight, irrespective of the dose of tirzepatide. If you're looking at more than 10% weight loss, at least 75% of the patient lost 10% of weight, and at least 50% lost more than 15%, and about 30% lost more than 20% with the 5 milligram dose of tirzepatide. So if you're looking at what proportion lost more than 10%, so 9 out of 10 would have lost more than 10%, and 3 out of 4 would have lost 10% of weight. That is pretty significant. Now, what proportion lost more than 50%? You can see that at least 20% weight loss happened in more than 50% of the patients with the tirzepatide, which is again pretty dramatic. So 8 out of 10 patients with 15 milligram of tirzepatide lost more than 15%, and 2 out of 3 lost more than 20% with the tirzepatide 15 milligram dose. Now, when you're losing weight, one of the things that you have to be aware is, what is your body composed of? Your body is composed of water, bones, your gut, organs, intestine, muscle and fat. What you essentially want to lose is fat, and you don't want to lose muscles. And in all of the anti-obesity trials, you can see that the weight loss that has happened, about 80% of that is fat loss, and about 15 to 20% is muscle loss. Now, part of that could be intramuscular fat loss as well, because the DEXA scans that we use cannot differentiate between the decrease in the muscle volume versus the intramuscular fat loss. But predominant weight loss is the fat loss. And one of the things that we will all have to learn, and we will all listen in the years to come, will be drugs that will preserve muscle mass, and resistance exercises and training exercises through which we can maintain muscle mass when we are using such anti-obesity drug. So as ancillary cardiometabolic benefits, you see in these studies that there is a significant reduction in blood pressure, close to about 8 millimeters of mercury in systolic, 5 millimeters of mercury diastolic, dramatic improvement in the triglyceride levels and LDL cholesterol levels. Now, coming to the second study, which is actually Surmount-5 in this particular slide deck, all of us are interested and all of us keep comparing apples with oranges. I think it's unfair to do it, but somehow Lilly decided to do a study comparing semaglutide with tirzepatide. Remember, the only hitch in this study is this is an open label study. So people knew who was using what. So that's one of the limitations. Nevertheless, people had this kind of a up titration regime, and the maximally tolerated dose was offered to both groups. This is a phase 3B, multi-center, randomized, parallel arm, open label, active comparator control study. And what you see at the end of 1.5 years is, at the end of 1.5 years, the weight loss with semaglutide was about 15%, and the weight loss with tirzepatide was above 20%. So significant difference in weight loss of about 5% when you're using tirzepatide as compared to semaglutide. And if you're looking at the proportion of people who achieved at least 25% reduction in body weight, 1 in 3 patients on tirzepatide lost at least 25%, whereas only 1 in 5 individuals lost 25% when you use injectable semaglutide. So if your weight loss is your primary reason why you're using the drug, probably tirzepatide scores over semaglutide. And you essentially want to lose fat from the wrong areas, right? You want to lose belly fat. You want to lose visceral fat. So as you can see here, the waist circumference change is almost about 20 centimeters with the tirzepatide or Mounjaro. One of the things that you can remember is every percentage weight loss that you have will lead to that number of centimeters of waist circumference reduction. So 10% weight loss will be 10 centimeter waist circumference reduction. 20% weight loss will be about 20 centimeter weight loss, waist circumference reduction. So what happens when you discontinue tirzepatide? So this is from the Surmount-4 study. So here you see for the first period, that is up to week 36, people were up titrated to tirzepatide either to 10 or 15 milligrams, whatever they tolerated best. And then there was a period when they were randomized. One group continued the tirzepatide and the other group was then switched over to a placebo. And at 88 weeks, you are now trying to see what has happened to these individuals. So, not surprisingly, in the placebo group where you had stopped the drug, the weight regain was there. And the regain was close to about 10%. So, initial period there was a 20% weight loss at 36 weeks, and about half of that weight loss was regained if you stopped the drug. But if you continued the drug, there was again a further sustained 6% weight loss at 88 weeks. What about adverse events that we are talking about? Because all of these drugs will have some problem or the other. And the major problem is essentially GI side effects. So nausea, diarrhea, constipation, all that was discussed with semaglutide is also there. And this is in the Surmount-1. All of the GI side effects is similar to all of the previous GLP-1 studies. Now, is there any difference in side effect between tirzepatide versus semaglutide? So this is from the Surmount-5. You can see that the GI side effects are almost similar in both of these groups of people. Surmount-4, where you actually had a continuation phase with placebo. Obviously, in the placebo phase, the side effects came down and the GI side effects continued in those who continued with the active drug. So if you summarize, tirzepatide significantly reduces body weight by an average about 16% with the 5 milligram dose and above 20% with the 15 milligram dose. Tirzepatide in the Surmount-5 study demonstrated superiority over the semaglutide. Again, remember it was an open label trial, and it improved key cardiometabolic parameters including blood pressure, waist circumference, triglyceride, HDL cholesterol. And the most common adverse reactions were gastrointestinal, which were mostly mild to moderate, and it happened mostly every time you up titrated the dose and was transient. I shall stop there, and before I finish, I would invite all of you to join us at the National Conference of the Endocrine Society of India beginning of next month. Thank you very much.
Thank you, Dr. Sujoy Ghosh, for such a nice and extensive deliberation on tirzepatide, which is latest molecule as an anti-obesity drug. My question is that are there side effects, GI side effects somewhat different between semaglutide and tirzepatide?
It's almost the same.
Almost same. Only theoretical. Only theoretical that GLP, GIP is both agonist.
See, we have now data from the Surmount-5 which have looked at the GI side effects, which is identical in both the groups.
There is no difference in side effects. So this session is open for any question and comment.
Thank you.
I request Dr. Kaushik Chaki to felicitate Dr. Sujoy Ghosh and Dr. Silima S Tarenia. We have already felicitated Dr. Emil Bhansali beforehand. Thank you all.